So this lecture is overview of gram-positive cocci and gram-positive rods of clinical significance. Sort of a broad topic. So we won't be covering everything about all of these today, but more giving us a framework, reviewing some of the micro behind it, and some of the sort of taking it a step above your med student residency lectures for things ID fellows need to know. And then also anaerobic bacteria we're not covering in this because there's another lecture dedicated to those. Okay, so you guys have done this before. So gram-positive cocci, how do you split them out? How do you think of it in your mind? What different groups? Yep. Yeah, definitely clusters, pairs, and chains. And then sort of corresponding with those is often the biochemical test looked for is the catalase positive or negative. So catalase positive are your staphs, catalase negative are your strep and strep-ish groups. And then within staph, how do you guys break it up? Yeah, exactly. It's like in the name of the other big group of staph is by coagulase test. And then strep, how do you guys divide up strep? We're going to go through all these in more detail, but this is the big overview. Yeah, that's a big one. So and throughout the years, decades, there have been different ways of classifying strep. But the big one is really by the hemolysis, as you were saying, alpha hemolytic, beta hemolytic, gamma hemolytic, and then you can sort of put in the different groups underneath those, with the gamma hemolytic being Enterococcus, which you could also sort of put as its own category along that second row. That's sort of the broad overview. So now we're going to go through each of these in a little more detail. We'll start with our favorite staph. And I just want to start by seeing if you guys knew what the coagulase test was, if you recalled what that actually means. Yeah. Yep, exactly. So, and you see them, they actually do this, and it's really quick. They just take it, add the sample, add the plasma, and then they see if it clots. And if it does clot, which are those little spots on the slide or in the tube, I've usually seen it done on the slide in my micro lab and fellowship, then it's coagulase positive. And that means it's Staph aureus. And being coagulase positive is sort of one of the sort of virulence factors for Staph aureus. It can form clots, gives it a little more strength as an infection. Here's what Staph aureus looks like in the microlab. So on the left is what it looks like in the Petri dish. This is the one I think we're all pretty familiar with. It's yellow, the aureus in the name. It's beta hemolytic. So you can see some clearing of the blood agar. And then if you look at it under the microscope, you can see the GPCs in clusters. We are not going to go through all the clinical manifestations of Staph aureus today. It's sort of beyond this talk and fits better into more clinical syndrome presentations. But just highlighting that we see this pretty much every day on our consult surfaces. Staph aureus can cause all sorts of infections, complicated and otherwise. And so I did want to highlight just a few staph-related things that we think about a little less often and come across on the wards a little less often. So this is a case, a 78-year-old man. He has squamous cell carcinoma of the neck, getting radiation and chemotherapy. He also has CKD, and he presented with a desquamating rash on his right forearm and left cheek. This is the picture of his forearm, sort of elbow spot rash. It looked pretty similar on the cheek with that peeling skin. And so this is toxin mediated, but which toxin is causing this rash? Do you know what any of these toxins are?
This is called its insert.
Yeah, Amr got it. So exfoliative toxins causing Staphylococcus scalded skin syndrome. What are the other things listed there? What's TSST? Right. And I didn't give you a great story on this one, but he wasn't shocky. Lipopolysaccharide. Which type of bacteria have that one? Yeah. And then enterotoxin, particularly related to staph. Do you know what disease that causes? Yeah, your GI illness. So ingestion of formed enterotoxins. And so since I presented a case on this, the staph scalded skin syndrome is due to Staph aureus, and it's mostly kids, so we really don't, this is not common in adults, but where you will see it is immunocompromised and people with CKD. Sort of hypothesize that maybe the renal failure, you don't clear the toxins as well. I couldn't find that that's been proven. And in clinical, it has that the rash, and then that we saw in the picture before, and it can be confused sometimes with some of our drug reactions, SGAS-10, but staph scalded skin spares mucosal surfaces, so you will not see mucosal involvement here, which is a key differentiating factor. If you get a biopsy, you also see different pathology with staph scalding skin having intraepidermal cleavage. If you see this, you treat for Staph aureus. You often will have a positive blood culture, though not necessarily always. Sort of tied to that, as we sort of discussed in the question already, Staph aureus has a ton of virulence factors. I just highlighted a few that are probably more boards worthy for being associated with particular syndromes of clinical importance. This is sort of a random slide, but one other thing I highlighted throughout our gram-positives is that we always like to, think vancomycin is great empiric coverage for all gram-positives. It's sort of something that I hear a lot, but so I wanted to we'll highlight some vanc-resistant bugs later, and then in this case, just for Staph aureus, what's more common is MRSA resistance or MRSA, methicillin resistance. So I wanted to make sure we were all comfortable with the mechanism of resistance. Are you guys familiar with MRSA? Okay. And so this graph figure, I think, is a simple diagram that shows how MRSA works. And normally you'd have the PBP2, which can bind the antibiotic. You can see in this nice little figure, the antibiotic fits in there well. And so the antibiotic can prevent building that cell wall. And then in PBP2A, which is what's produced by MRSA, that has a low affinity for beta-lactams. They can't bind it, and so the MRSA can go on its way happily in the presence of penicillins and beta-lactams. That was sort of the Staph aureus overview. You'll hear a lot more about staph as we discuss different clinical syndromes throughout lectures over the year. Next is coagulase-negative staph. And so this gets to the point Amra was making before the lecture started, that a lot of these GPCs, and particularly coag-negative staph, you're always wondering, is this an infection or contaminant, right? I'm sure you guys have gotten many pages about, there's a staph epi in the blood culture, what should we do? And so when do you guys, it's on the slide because it's not animating correctly, but when do you guys get concerned that the staph epi or the coag-negative staph in the bloodstream is actually truly an infection that needs to be treated? Yeah, it's there, but yeah, looking at the burden of disease, are you growing this multiple times? And then making sure the host, the clinical setting, the presentation all would fit with this as a true infection. Things like intravascular devices, lines, and then any prosthetic material, coag-negative staph can certainly stick to and cause true infections of prosthetic things. And maybe the species. There's a lot of different species of coag-negative staph. A few that could come up a little more commonly, staph epi is just the most common overall. It's the most common skin colonizer. It's most commonly isolated. I would say we mostly see it as a contaminant, but it can form biofilms causing those hardware or prosthetic infections. Have you guys heard of Staphylococcus before? Yeah, that's one to certainly always have your radar up for. If you get a Staphylococcus, most people would say treat it like Staph aureus. It's much more virulent than your other coag-negative staphs and acts in a way much more similar to Staph aureus. Staphylococcus can be penicillin susceptible, which is sort of interesting. So you can ask your microlab to check that. Staph hemolyticus has been associated with NICU outbreaks and is, and there have been reported cases of resistance to glycopeptides. So that's why I highlighted that as one to keep in mind. And then Staph saprophyticus can be a cause of uncomplicated UTIs in sexually active women. And you guys know there's plenty more, and you sort of evaluate them as they come, but these are some of the key names to be aware of. That's sort of our rapid overview of our staph gram-positives and clusters. So we'll move on to the other half of this diagram, the strep species. And so when we talk about hemolysis, what do you expect to see with the different types of hemolysis? Like, what does alpha hemolysis look like? Okay, great. So I found this really nice picture that, yeah, and so this is important for micro, and they'll talk about this in micro, and they'll assume that you know what it means when they say you can see the beta hemolysis, and you'll be like nodding along, and you truly don't have a clue. So I like this picture because it sort of sticks in my mind pretty clearly. So when you're looking at a blood agar plate, you can see the beta breaks down the blood, and so you have clearing of the underlying agar. And so that's why that beta, you see the clearing, you can see through it. Alpha hemolysis has a green tint to it, hence that little alpha green. And then gamma hemolysis doesn't have an impact on it. And so they just like wrote a gamma on there basically, but it's not impacting the underlying agar. And so this is the sort of the most commonly used. It's easy to see in the microlab when they're looking at a Petri dish. They will describe it by this. I highlighted the classification systems. One of the other ones often used is Lancefield classification. You look at different cell walls. There are a bunch of different ones. They sort of correlate with the hemolysis, sort of not. It's a little confusing. I would say most of us clinically go more with the hemolysis in terms of how I keep them straight in my mind. So we're going to start with the alpha hemolytic, some of those greenish colony ones. So the first one is strep pneumo, pneumococcal disease, leading cause of pneumonia, bacterial meningitis worldwide, particularly young kids and older adults. You guys know how this presents: otitis media, sinusitis, pneumonia, and then really severe, potentially invasive disease with meningitis, bacteremias, and pyemas. This is a slide. You can see some of those gram-positive cocci, sometimes in pairs or short chains. And pneumococcal pneumonia is sort of interesting because of prevention. There's vaccines available, and we're going to go over some of that. This is when pneumococcal vaccination was introduced in 2000, when PCV7, the conjugate vaccine with 7 targets, was introduced. So this is looking at the trends in invasive pneumococcal disease among small kids. So this is the population that was being targeted for vaccination. And so you can see that over the following decade or so after this vaccine was introduced, there was a dramatic drop in the number of pneumococcal infections. And they highlight those blue bars are all invasive pneumococcal disease. The gray bars are PCV13 serotypes. And so you can see in 2010, they then introduced PCV13, highlighting or focusing on more than the PCV7. And you saw a further reduction, though the numbers were already sort of low, so the absolute reduction was less. What was interesting about this vaccination campaign is that it also impacted other age groups other than just kids. So this is the trends among elderly people greater than 65-year-olds. And so you can see that after the PCV7 was introduced, you had a drop in cases. And then once the PCV13 was introduced for kids, you began to see another drop, particularly in the PCV13 serotypes, that gray bar, even among these elderly population, before it was recommended for that age group. So this has been sort of highlighted as a success of a vaccination campaign. You're sort of decreasing the community burden of disease. We now have, do you guys know what vaccines we now have for? Yeah, so the 13's gone, basically. There's the 15 and the 20. It has 15 serotypes, the 20. And we still have the polysaccharide vaccine 23, the PSV 23. So I know you guys probably all learned how to vaccinate people. I know you guys do this in clinic. With our PPSV 23 and PCV 13, we learned about the rules for how to do that, in which order. Well, now that's sort of gone. So now it's actually a lot easier. So start on the right side. Yeah. So it's actually easier in people who've never been vaccinated in particular. So if you have old people, 65 or older, and they've never been vaccinated, you either give them PCV 15 plus our polysaccharide vaccine a year later, and then they're done, or you just give one dose of PCV 20. So obviously, if you have access to PCV 20, you just give that, and then you're done. It gets a little more complicated when they've received some pneumococcal vaccines before, but maybe not the full recommended series of the Prevnar plus the polysaccharide vaccine. And so that's what the left side is getting at. So they want to make sure these people 65 and older are fully vaccinated. And basically you want to, if they've gotten the polysaccharide, you give just one of these newer ones, conjugate vaccines, and then they're done. If they've gotten the PCV13, you can do one dose of something else, basically, they say, and then you're done. And then that was for people 65 and older. It looks sort of cut off on the top, but if people are 19 to 64 with risk factors, so for example, our HIV clinics, everyone's at risk. So everyone we recommend vaccination for. There's a lot of other things, chronic medical diseases, CSF leaks, cochlear implants, immunodeficiencies. And so if people don't have risk factors, that's that simple no on the left, on the right, they no longer recommend vaccination. But you'll find a lot of your patients you see do meet one of those criteria. And so then it sort of goes to basically the rest of it's the same as it was for the prior slide, where if they've never been vaccinated before, go for the PCV 20 if you can. There is a slide, or there is like one line I can find on the CDC vaccine guidance about what about if your patient has been fully vaccinated for with their Prevnar, their pneumococcal vaccines, and they're fully vaccinated, then do you need to give them the PCV 20 on top? And all there is a line that says there are no recommendations. The incremental benefit of PCV 20 on top of the prior vaccination is unknown. So. No, it's just one and done, at least as of now. I mean, these guidelines keep changing every few years. So for now, you're done with that. Yeah, so it will be simpler. It's just going to be sorting out some of these people who've gotten partway through their vaccines before this. I don't write the test questions, and it takes a few years. So I would say probably not. Yeah. This is more so you can confidently present your patients at the health department to me, and we'll all be on the same page. So that was a little bit of a side note from this talk. Okay, now we're going to get back more to some of the overview of GPCs. And so here's a question. This is an appropriate Moffitt case. So you have a 42-year-old man with sudden onset fever and collapse. He was started on induction chemo for AML 10 days earlier. He was taking prophylaxis, Cipro, antiviral, antifungal. And then his data. He was febrile, a bit tachycardic, hypotensive, tachypnic. His physical exam, widespread crackles. He had mucositis. He looked ill. His ANC was 0. Chest x-ray showed diffuse bilateral infiltrates. Blood cultures pretty quickly turned positive with gram-positive cocci. So which gram-positive cocci do you think is causing this? Yeah. I was hoping you guys would feel confident in that one. And why do you say E? Yeah, exactly. There's a pretty recognized association of Viridans group strep bacteremia causing very severe disease, almost a gram-negative rod sepsis type picture, and potentially with the development of ARDS. And so Viridans group strep in other situations are one of those that if you have one in a blood culture, you may wonder what to do with it, but not in the setting of that neutropenic patient. And Viridans group strep, there's a bunch of them, and again, they get classified different ways. I just listed some of the names just so you have a sense of what we're talking about. They're normal flora of GI, GU tract, but can potentially cause disease in the right setting, can cause endocarditis, subacute. Okay, strep anginosus is sort of, some consider it a subgroup of Viridans group strep. Do you guys know what strep anginosus is mostly known for, the group? Abscesses, exactly. So strep anginosus, strep constellatus, and intermedius. And they are, again, a normal part of the GI tract, oropharynx, urogenital, but they can cause abscesses. And so if you do isolate one in the bloodstream, you should be looking for the abscess or the source of infection somewhere. And, they can cause all sorts of different infections, basically related to an abscess forming somewhere most of the time. Can also cause endocarditis, less likely. There is a thought that this group in particular may have a synergistic effect with other bacteria where they become more virulent in the presence of other bacteria. They're often part of a polymicrobial infection with anaerobes. So often, especially if there's an abscess, when you're treating them, you're going to get source control of the abscess as needed. And then you often cover a bit more broadly. You don't narrow in on just the strep. You usually include anaerobic coverage as well because of the propensity of this bug for polymicrobial infection. Okay, so now we're going to move to beta-hemolytic. And what did the beta-hemolytic look like on the agar on your Petri dish? Clear. Yep. Okay, good. We got that. Okay. Okay, so we'll start with the question here. Remember this question? Oh, I do. A 54-year-old man presented with left leg pain and swelling. He had a minor injury where he bumped his leg a few days before. He's febrile, tachycardic, blood pressure is okay. His left leg is red, it's indurated, it's swollen, and he has a leukocytosis. He was rapidly progressing. They started antibiotics and they took him to the OR because they were concerned about neck fash, given how rapidly his leg was worsening. And op cultures grew strep pyogenes. So he was switched to IV penicillin G. And what antibiotic would you guys add to penicillin for this infection? And why? Yeah, and there's a fair amount of data showing that adding clindamycin to penicillin for these severe strep pyogenes infections is better. Yeah, this is a really pretty picture of strep pyogenes group A strep. It can cause a few different categories of infections. You guys have come across them all before. Strep pharyngitis, which is what this picture with those exudates seen on the tonsils. There's a bunch of different skin and soft tissue infections. We're going to look at the pictures next of a couple of them. Other serious infections, scarlet fever, bacteremia, pneumonia, neck fash. And then the big concern with this group is often the post-infectious sequelae, rheumatic fever, and glomerulonephritis. Have you guys seen rheumatic fever? One had a case recently. I think people do different things. I haven't found any convincing evidence of a duration for that, usually until they're better. Like in that case, it probably would have been better to have it on upfront than adding it once they've taken to the OR and been debrided. At that point, you could almost argue, they're probably much better at that point. That's what we learned, but I don't know that that's actually accurate. Yeah, when I was reading, it said it can be after other infections as well. But I remember learning that in the past, and it's not quite right. So what's this called? Erysipelothirx. Great. Yes. So, and I have gotten erysipelas consults in the hospital. And so you see it's very sharply demarcated. It's usually the face or the leg. And it is red and angry looking. What's this? Impetigo. Is impetigo always strep? Yeah, it actually can be staph as well. And this is one of those rare things, you can actually culture those and see if it's staph or strep if you wanted to. And then these pictures are a little hard to see. You can see the top picture, there's like whitish around the mouth. And then the bottom one is more of like a sandpaper-like texture. Scarlet fever. Yeah. Just like, was it Beth in Little Women? And so scarlet fever follows your strep pharyngitis usually. You can also have a strawberry tongue. I didn't include a picture of that. And that circumoral pallor is sort of a clinical feature of it as well. Rheumatic fever, we'll discuss more in a future lecture, but these are just the major criteria or the criteria you're looking for in the setting of someone who's had a recent strep infection or some reason to think they have. And a key point that comes up on the boards, and there are guidelines for this, is if people have rheumatic fever, they need secondary prophylaxis with antibiotics, and there are variations in for how long they need it, 10 years until they turn a certain age. I didn't include that all here, but it is something that can be tested on boards. And then just rounding out strep or strep type bacteria, a few other ones that I didn't have a lot of pictures for. Group B strep. Our main concern with that is in pregnancy, neonates. It can cause pretty severe neonatal infections, so all pregnant women are screened for that. It can cause other infections as well, but that's the most common setting. Strep galloliticus is the one that if you see that, you think, do they have GI malignancy? Used to be strep bovis. Leukonostoc is sort of similar to strep. It's sort of moved down into its own group, but it's intrinsically resistant to vancomycin, which I think is an interesting one. And then our nutritionally variant strep, so Aphiotrophia granulicatella. These are known for causing endocarditis, is what you always think of when you see them. And then our final sort of group of the gram-positive cocci, Enterococcus. We could talk about Enterococcus for days, but this is overview. And so they're a normal part of the GI tract. But where we see them cause problems is in the patients you guys see in the hospital every day. People who've been hospitalized, who've had broad antibiotics, a lot of nosocomial exposure. Which one's easier to treat, faecalis or faecium? Faecalis, yeah. Faecalis is much more susceptible to vanc and amp. Faecium is much trickier. And then a board type potential topic, just vancomycin resistance and enterococci. So which species are intrinsically resistant to vanc? Yeah. Yeah, there's two of them, but good, you got one of them. And then Gallinarum. And they have a chromosomal Van-C. Van-C is the mechanism for that. Otherwise, vancomycin resistance in enterococci in the US is usually due to Van-A. They just named the mechanism, the enterococci vanc by Van A, B, C. There's a whole bunch of them, but Van A is the most common one in the US. And it encodes cell wall precursors. It changes the final amino acid so that vancomycin is not effective. And that photo there sort of shows you how changing the shape, it's a schematic of how changing the shape will change how it fits. Okay. And then the end of this is just a quick review of some of the gram-positive rods. These, we're not including the anaerobic, they're a separate talk. Some of these, like we were getting at, can also be contaminants, so they can also be ones you get called about, and you have to figure out whether you really think they're infection or not. It's a Corynebacterium. Yeah, this is it's often a contaminant, but this one is not, diphtheria. And you guys have probably all seen these pictures before of that grayish white exudate. And it's often in unvaccinated communities, very rare in the US, but you would have some sort of hint that it's an unvaccinated community that would make you think of this. And in addition to antibiotics, treatment is diphtheria antitoxin. And then there's a whole slew of other coryneiform species. These are a few that sort of come up as clear clinical associations. There are many others, so if you get a species you don't know about, you're probably going to look it up. But we've certainly seen cases of breast abscesses due to, I don't even know how to say it, Kropinski, I don't know, but I've seen it before at Tampa General a couple times. There's also species Jacqueline, striatum, ureolyticum that can be associated with nosocomial infections, and there have been outbreaks reported of these. And then it's no longer under Corynebacteria, but it's very similar. The Bacillus hemolyticum can produce a pharyngitis that's very similar to strep. And then, moving on to a different class or a different group, a 32-year-old woman presented with 1 day of fever, headaches, nausea, watery diarrhea. Her symptoms started 12 hours after a picnic. She ate pate, sandwiches, and salad. She was concerned, as she is, I don't know why, but was 6 weeks pregnant. So what's causing her symptoms? And why do you say Listeria rather than Bacillus or Staph aureus, some of these other foodborne?
Like less than 6 hours.
Yeah. Yep. And the other ones we aren't covering in this talk, so good test taking skills. But yeah, the Bacillus and Staph aureus, preformed toxins, those are pretty quick within under 6 hours. Listeria is usually more like 12, 24. And this also includes the additional clue that she's pregnant. Yeah. And so pregnant women have a list of foods they're supposed to avoid, often soft cheeses, deli meats, things like that. But then I went to the CDC website because there are Listeria outbreaks of other things that are not included in those general recommendations. Right. So as someone who's been pregnant recently in the past, this is a frustrating list to see because, like, you knock out ice cream, you knock out salads. So, yes. And the other just point is that if you see someone who's pregnant, they're sick, and you're worried they could have Listeria, but they're like, no, I don't eat any of those. Like, that's not convincing. Listeria is reportable for this reason, so they can do outbreak tracing. And we talked about pregnancy is the big one, also can cause disease in immunosuppressed patients, neonates. We talked about the GI incubation. CNS, there's technically 3 different presentations. And what's interesting about the CNS infections is that they can have a much longer incubation compared to that GI. So it can be days. I think the books I was reading cite a median of 11 days, but up to 28 days incubation before people present. And there was one case report of like 2 pregnant women who their only common activity had been like 3 weeks prior. They were at the same event where food was served. Something really weird, and both got the same strain of Listeria. So again, it may be hard if you have a patient with the right presentation and the right host, that's why we cover for it, even if we don't have a clear story. Meningoencephalitis is the most common presentation. Cerebritis is less common. And then rhomboencephalitis, involvement of the brainstem, it pretty severe, and that can occur in immunocompetent patients as well. And then we always worry about pregnancy complications.
Sure, but
Yeah.
quick question. Any thought on the mechanism of as to why pregnancy poses such a risk factor?
It's a great question. Do you want to look it up and let us know?
Okay. Stop asking.
No, actually, I intended to look that up and forgot because it's a great question, and I don't know. I don't know if anyone else knows off the top of their head.
Open.
Yeah.
Or-
Yeah, I mean, I've always heard it described as the relative immunocompromised status of pregnancy. I think you can think about it that way. So there's relative immunocompromised state that pregnant women achieve. That results in increased susceptibility to bacteria like Listeria and stuff.
Mhm.
Thank you.
Okay, I didn't even include a question with this, but what is this? Yeah, black eschar. There's some underlying edema. Good job. You guys are really good test takers. Yeah. I was hoping it would like at least give you a second to think about before you read it, but these are two different pictures of cutaneous anthrax. And so they show that there's the eschar, and it's harder to see in the neck is why I included the pictures of the hand. There's a lot of edema underneath it. And sometimes you can develop these blisters. So this is due to Bacillus and Erysipelothrix. Compared to some of the other gram-positive rods, Bacillus anthracis has a different morphology. It's much bigger, sort of, they call them boxcar-like gram-positive rods. And in this one, you can see where some of the spores are. They don't stain, so you have sort of like that skipped-looking area where there's no stain seen there. And they form these big, long chains. And then on the Petri dish, they have like, they call them Medusa head or comet trail appearance. It's sort of a unique appearance to the way the bacteria look. They also comment on something in slide B about a whipped egg white appearance, which I'm not quite as familiar with. I've never seen this in the lab. I'm guessing most of us have not. And so Bacillus species, the ones that we clinically concerned about, obviously anthrax. The vast majority of cases are the one we saw in that picture, cutaneous, where people develop a papule, develops into vesicles, and eschar. And there are some reports with heroin injection, which is interesting. And then the one we worry about is inhalational. This is the high mortality and bioterrorism risk. It can occur without bioterrorism in the setting of people handling wolves and hives. And then Bacillus cereus, we sort of hinted at in some of our other questions, where you get the mean form we talk about. The emetic form is listed secondly there, is very similar to Staph aureus. Heat stable, we always worry about rice. Heat stable means even when you microwave your rice, you can still get it. And then there's the second form, a diarrheal form, which is due to a different toxin, and that's a little slower in presenting. And then our last one, this is just sort of Erysipelothirx, can cause local infection, erysipeloid, localized cutaneous reaction. Often you'll hear that people had some sort of, like, there's board review questions about a crab fisherman who, you know, noticed some tenderness along the finger, then developed more of this lesion. It doesn't have like lymphangitic spread up the arm. And you treat it with antibiotics. But that's a picture of what it looks like, so you have it in mind. And that's my quick overview of gram-positive cocci and gram-positive rods.